All right, today I'm going to tell you 3 reasons not to get a knee replacement. I'm Dr. Tait. I'm a non-surgical orthopedic doc, specialist in regenerative orthobiologics, doing procedures like stem cells and platelets to slow down the aging of one's knee, help pain through a different mechanism, and hopefully keep people from getting over that point where they really need joint replacement. But I get questions a lot in my practice because many people call surgery the last resort, right? They want to work through every other step on the path, and if all those things fail them, then they're over here thinking about the joint replacement. So, the questions I get are, do I really need it? Am I a good candidate for it? Is there any other way out of this? Or is joint replacement the best possible thing I can get here? So if we look at a model of the knee, I want to recap what arthritis is for people that are new to the channel watching this for the first time, but the cartilage is really the cap on the end of the bone, okay? So in a knee joint, we have the thigh bone up here, the shin bone down here, and the cartilage cap on the ends of these bones, and those erode over time. And so as that cartilage breaks down, the body works through these stages of arthritis. And here's the interesting thing, it is not completely linear with age, meaning just because you're 40 doesn't mean it wears out this percentage, 50, 60, and beyond, because I see patients in my practice that are in their early 80s and have very well preserved knee cartilage. I see people that have been very athletic and maybe they've had some injuries like an ACL repair in their teens or 20s. And we see post-traumatic arthritis by a mechanism where this cartilage is wearing out much sooner than we anticipate or expect it to, compared to the normative data out in the population. So first we got to understand, with arthritis, at what stage are people getting their knee replaced? Obviously it's over here when the knee is really blown out and degenerated and the cartilage is almost completely gone. This is where somebody says they have a bone-on-bone knee. So 3 reasons I mentioned that I want to talk about today not to get a joint replacement is obviously you're in an earlier grade of arthritis in a younger age. No surgeon I work with wants to replace one's knee when they're young for one major reason. The lifespan of the components that are used to replace a knee only lasts so long. And if somebody is very active, say it's a younger person in their 40s, which I sometimes see in my practice, that they've failed out of a lot of treatments or the treatments have failed them, then they're kind of around this idea of replacing their knee. And if they do that and they remain active on that knee, they're going to need a revision on that knee 20, 25 years later. Okay, which is a more complex surgery and you're older at that point. So again, the goal is to preserve the knee as long as possible before we have to think about, and I have to refer out because I'm not a surgeon, but to my surgical colleagues who can replace a knee. So 3 reasons I want to talk about not to replace one's knee are from a pain standpoint, okay? If somebody has mild pain in their knee and their x-ray could look bad, there's a lot of other things we can think about in the maintaining of one's knee. Because if the range of motion is good in the knee and the structural alignment is good in the knee, but there's pain that's impeding the path and the obstacle in the path of what patients want to do on the daily for their activity, there's a lot of things that we can put inside the knee to help those symptoms. Conventional things would be steroids, which I've talked about in other videos, at dose, those being quite toxic to the joint. And if we're doing that repeatedly, it can actually accelerate the wear pattern of a knee. 2, I think a lot about mechanical corrections for joints in my practice. As a physiatrist, we focus a lot on function and movement. And so I'm always analyzing people from the floor up, meaning looking at foot mechanics and how they may change knee mechanics. So if somebody's got a really flat foot, and it flattens out and rolls in and changes the mechanics at the knee, well, that can impact their knee. So orthotic correction could be helpful. Or up here at the knee itself, if we have a compartment that's wearing out on one side, we can use a brace to unload that side. They're called unloaders. And those can be quite helpful to people to take the pressure and the compression off that bad area of the knee where the cartilage is quite inflamed, or the mechanism of that cartilage inflaming the joint. But with a brace, we might be able to offload that and help them, okay? So those are some things that we want to think through. But when somebody progresses over to this bad end stage, right, the let me reverse this. The 3 reasons I probably can't help somebody with a treatment like stem cells, because stem cells are one of the most powerful things we can use in non-surgical orthopedics. And what stem cells are the master helper healer cell in your body. And so stem cells self-repair, 1 million cells a second in our body are being turned over and replaced by new cells. So if we take stem cells from somewhere else in the body, from the bone marrow, usually from the hip bone, and we process that down in the lab to get this fraction of stem cells, and we inject it into the knee, we can stimulate a healing response in the knee. We can shut off some of that inflammation and chemistry in the knee that's degrading the knee. And that, even though somebody has a bad looking x-ray or an MRI, if we get the mechanical corrections dialed in on them, so maybe it's an orthotic, brace, sleeve, we get them in with a good physical therapist, work on the movement corrections and strengthening, because now that the joint pain is turned off, we can actually turn the muscles back on. And that can buy somebody a significant amount of time in the knee. In my practice, we have people, some of them 7-8 years out after a stem cell treatment, that are still not reporting high levels of pain, even though their x-ray looks bad. So one of the reasons then not to get a replacement is, again, if your functionality is where you want it to be and your pain scores are low, there's really not a need to go after the joint replacement. We kind of get there because we fail out of these other treatments, or those treatments again fail you to get the result. But where somebody isn't a great candidate to do things that I do is, look, if the pain is so debilitating and nothing we put in there can turn that pain off, you're probably at a point where we have to really have a serious conversation about thinking about replacing the knee. 2, if the knee is angulated, so again, as the knee breaks down, it can become more knock-kneed or bow, and that cannot be changed with stem cell treatments, no matter what people are claiming in different far-reaching corners of the internet. Once your knee breaks down to that point where you have an angulation in it, we measure these things out in my office, and we know that if they get beyond a certain, few degrees of angulation, those are really hard to treat. Now, we can correct that angulation with a brace. We can turn the pain off with something like stem cells or platelets, but ultimately, it's hard to physically correct that once that is there. So again, if it's correctable on exam and we can get a brace fit on that patient to offload that further decline in angulation of the knee, use stem cells to shut off the pain, people can do very, very well. But if their mechanics are already compromised so much that now they've lost the range of motion, their ability to flex this knee or straighten it all the way, because of that knee arthritis, that is a very, very hard thing to change with a cellular treatment. Again, can we shut off pain? Yes. Can that person have a better life with the pain shut off in their knee? Of course. At that point, can we strengthen them and use all the other things we do to give them a more functional knee? Yes. So, those are really the short list of reasons around, why is somebody going to do good with maybe an orthobiologic treatment like stem cells or platelets, or why wouldn't that person be a good candidate from the beginning, that I may exclude them and send them over to one of my surgical colleagues to have a consultation regarding replacement. Because look, joint replacement is one of the most transformational things that we can do in orthopedics. If somebody gets to a state where their knee is this bad, it's hurting them every day, they can't even sleep because of throbbing knee pain, waking them up several times a night, and the patient can be brought to an OR and that knee replaced in about an hour's time, once they're out for the procedure, and they can be up walking around on a new knee that day. I mean, that is pretty remarkable and pretty transformational for patients that get it. And, joint replacements have been done since 1968 was the first one, and they continue to evolve. The technology gets better. Right? These implants are better. The wear time on them are better. The robotic assist and computer assisted programs that are being used to analyze best fitted components and everything to get the patient the best possible surgery, all that stuff continues to get better. But by and large, if somebody is not wanting a joint replacement, there are a lot of treatments to look at in this non-surgical space now, and they're only evolving. So just like the technology of surgery is coming along, and it's less invasive and people are back to activity quicker, and the materials are getting better and the wear times are getting better and all those things are getting better, The same goes for platelet and stem cell treatments that have been used, in the U.S. since the 1990s and continue to evolve as the technology gets better and our understanding gets better. And there are other things out there with biomaterials and other components that can be integrated with stem cell treatments that are being studied right now. So the future is bright for one, surgical interventions to get a whole lot better, right? Continuing to advance that technology, wear times, everything else. And also in this space, on my side of the fence of a non-surgeon orthopedic doc doing stem cells and platelets and things like that, this technology is only going to get better. Our understanding of it's going to get better. And the key to all of it is really early intervention. So, are there alternatives to joint replacement? In summary, yes, there are. What are the 3 reasons I would not recommend a knee replacement to my patient? Is that one, their age is young and we haven't tried these other treatments. Okay, their functionality with the knee is still great from a range of motion, alignment, and stability standpoint. Would not recommend it, again, if we haven't tried these other treatments. And really the third one is pain. If somebody's quality of life can be improved with the pain turned off, then we want to keep them in this state, especially in a younger middle-aged patient, to keep them there as long as we can, to slow this progression of arthritis in the knee so that we don't arrive at that last resort too early in life. And if we can kind of kick the can, proverbially down the road with these other treatments that, in my practice can last people 3 years, 5 years, again, like I mentioned, some of them 7, 8 years out, applying all these other things around the treatment to keep that knee functional, less painful, healthier, and kind of halt this progression in a way of going down the hill as fast, well then those are all very viable treatments that people should explore, in my professional opinion, before they go to replacement. So hopefully that gave you the high level on replacement, what it is. When do we get there for some patients? What are the other alternatives that we can think about for patients that aren't ready for replacement? And if you like content like this, like the video and subscribe so that you can see when we post up new things. And if I can help you in any way, we always put a link below all these videos. That's a direct link to my practice. And if you're local or regional out here in the Southwest, we'd love to talk to you about your case, see if there's anything we can do inside of our practice that's a good fit for what you're dealing with, to help you pain less and live more and get out there and do the things you love doing.